So good afternoon, everyone. We start this subspecialty session with our first talk. Dr. Parth Rana is going to talk to us on dot and blot hemorrhages. So this is basically for a very basic discussion. So everybody is invited to actively participate and give in your inputs to make the things more and more clear. We've almost started a little 5 minutes late, so let us not waste any more time. Let's quickly try to finish the discussions. Over to you.
Thank you. Thank you for allowing me to present earlier. Sorry for skipping the queue. I have a ICE in Holland. So today I'm going to present on dot and blot hemorrhages. So it's a very basic topic. So today's my overview for presentation is origin of dot and blot hemorrhages, common causes and how to differentiate, and when to refer. So if we see, this is a basic presentation for just who has passed out for their post-graduation. So these are how dot and blot hemorrhages looks. So what these are dense, dark red, sharply outlined, and are seen in disorders that are affected the prevenular deep capillary layer. And if we see for the origin, it's microaneurysm occurs secondary to capillary wall outpouching due to pericyte loss, and they appear as a small red dots in superficial retinal layers. And there's fibrin and red blood cell accumulation in microaneurysm lumen, and the rupture of that produces blot or flame hemorrhage. So if we see dot and blot hemorrhages occur as a microaneurysm rupture in the deeper layers of the retina, such as internuclear layer, outer plexiform layer, and this appears similar to the microaneurysm if they are small, and fluorescein angiography may be needed to distinguish between the two. So these are basically intraretinal hemorrhages. So if we see common diseases and differentials for that, so the location, size, and the distribution of the hemorrhages provides clues to the etiology and uncover underlying systemic disorders such as vascular disease, hematologic disorders, and dyscrasias, and infection, trauma, and hypoxia. So if we see in diabetic retinopathy, we see dot and blot and vitreous hemorrhages can also be there. Bilateral diffuse distributed in the posterior pole dot and blot hemorrhages, we see in that. If we see in RVOs, diffuse intraretinal hemorrhages in all quadrants, in central vein occlusion, and sectoral distribution in branch vein occlusions. So here we can see on the left side it's on superior hemi-RVO, and right side we can see CRVO. So here also one post-op case where inferior hemi-CRVO is there. And ocular ischemic syndrome, if we see in that mid-peripheral intraretinal hemorrhages can be there, retinal neovascularization can be there, and sickle cell retinopathy. If we see intraretinal Sanman patch hemorrhages, and with that black sunburst chorioretinal ischemic scars and CFAN neovascularization, which might lead to vitreous hemorrhage, and they are seen usually bilateral. So in juxtafoveal telangiectasia, if we see, it's a typically central dot and blot hemorrhage with the chorioretinal scar and vitreomacular traction. So if we differential according to the age group, so there can be neonatal if hemorrhages are there, then they are from birth trauma, including spontaneous vaginal delivery, vacuum extraction, and double instrument deliveries can also cause that. Infant and children, if we see child abuse, coat disease, persistent hyperplastic persistent vitreous, retinopathy of prematurity, retinal dysplasias, hypertension, myopia can cause that. In systemic, if we see hematological or cardiovascular disorders, infections, protein C and vitamin C deficiency can also cause that. And adults, if we see diabetes, hypertension, leukemia, blood dyscrasias, hypoxia, anoxia, and high altitudinal syndromes, high myopia, posterior vitreous detachment, retinal tear, and detachment can also cause that. And if we see treatment, it's basically total systemic treatment or systemic workup we have to go for that to detect underlying cause for the hemorrhages. And management consists of observation and treating the primary cause. and intraocular management to reduce the ischemic and neovascular sequelae following the hemorrhages. So if you see, most dot and blot hemorrhages are not vision threatening and are usually found in the posterior pole sparing the fovea and can be observed. And hemorrhages seen in the retinal vein occlusions are not treated per se, but the retinal edema or the neovascularization which follows as a sequela needs to be treated. So in take-home message, if I'll say, sometimes dot and blot hemorrhages can be the tip of iceberg. We need to investigate for the ocular findings by OCT, OCTA, FFA, and for blood investigation. And if we need, we might have to refer the patient to the specialist like retina surgeon, physician, endocrinologist, rheumatologist. And timely referral can save the patient from potential complication. Because as I told here, it can be the tip of iceberg. As per se, dot and blot hemorrhages are not the disease. So we need to treat the disease basically. Thank you.
So very nice overview of these fundus findings, dot and blot hemorrhages. And you rightly pointed out, Dr. Parth, that it's the coexisting features in retina which help us make the diagnosis. The dot and blot hemorrhages only bring it to our attention that there is something wrong in retina. There are very few conditions where you will have isolated dot and blot hemorrhages and nothing else. I think one can be an impending PVD and second can be venous stasis retinopathy. It's a very incipient kind of CRVO, often related to high pressure, and sometimes sudden hypotony can also lead to isolated dot and blot. Otherwise, you rightly pointed out all the common reasons for dot and blot hemorrhages.
Yes.
Maybe Madam can add something. Or
Yeah, I think the most important thing is the systemic issues is what we have to look after. So this is just one place in the eye or in the whole body that we can see that there is a pathology, and we have to be a good investigator here to see what is going wrong.
True.
Sometimes you do see microaneurysms or hemorrhages, and there is a very strong family history of diabetes, but the patient doesn't have diabetes. I have seen it very often. So possibly there is a gene for diabetic retinopathy that is inherited without having diabetes as well. So it's not necessary that every microaneurysm has to be pathological.
Okay. Thank you.
Thank you, Dr. Parth.
Yes, thank you.
Now I'll invite Dr. Mohit for his talk. He needs no introduction. He has witnessed retina right from the beginning, and he'll be speaking on grayish membrane at macula. Dr. Mohit, over to you.
Thank you, sir. Hi. Thank you. Yeah, thank you, sir. And I'd like to thank the entire panel for this opportunity. And I have 6 minutes going by that, so I'm just going to try and keep it short. And it's going to be fairly basic, so let's see how this goes. So basically, if you want to look at grayish pathologies in the macula, I substituted the term membrane with pathologies. So these are the quick kind of checklist of conditions that you want to look at. And we're not talking about black pigmented lesions because that's a different kettle of fish, but you have mactel, you can have epiretinal membranes, which, you know, if they are strong enough and if they are pulling long enough, can cause RP alterations. You can have macular neovascularizations, type 1, type 2s. You can have areas of RP alterations, which can be RPE, RIPS, could be, RPE atrophy, could be, other changes in certain other diseases like chronic CSR or whatever. You can have choroidal nevi, or you could have, faint laser photocoagulation scars. And typically in the macula, you would have lesser power. You would hope and pray that you would have lesser power burns. So they would not typically be black, they'd be grayish. So you can have all of these, or you can, and the list could be longer, but I think the first 3 or 4 are the ones which are the commoner ones. And before we get on to 2 cases, which will show 2 of these common ones, I just want to show one more slide, which is this, which is basically, for our anterior segment colleagues, for general ophthalmologists, for, people who do the most common surgery, which is done worldwide, which is cataract surgery. So you have lots of papers. I've just put up 2 there. So proponents of doing routine OCTs prior to all cataracts, and not just premium IOLs, but all cataract surgery. So in different populations, different populations is important because the fundus pigmentation is different. They've been able to detect, the OCT has been able to detect occult lesions up to the tune of 5 to 12%, when apparently a clinical exam preoperatively was normal. And of them, because of the cataract, the contrast might be gone, but the top three are, ERM/VMT, a choroidal neovascular membrane, or MACTEL. All three of these are also gray pathology. So the color may not be as gray if there is a media opacity, and the most common of that being cataract. With that, I'm going to just again show two cases. Case one was a 44-year-old female. She had complaints of insidious onset blurring of vision in both eyes, left more than right for the past 3 to 4 months. The left eye you can see there, and the right eye was that. So she had, I think it's fairly, she has that gray kind of structure in the right eye, just temporal to the fovea. The left one is a little more pronounced, also has what looks like a rim of fluid around it, has more volume. And that's the OCT passing through the fovea of both the eyes. The right eye showing you the typical eye limb drape and the hyperreflective foveal space. The left eye showing you SHREM, and it's also, although not showing some subretinal fluid, but there's very subtle intraretinal fluid. So it's not a diagnostic quandary. You know what it is. Sorry. Yeah. So I mean, we went ahead and did a OCTA for these, and you can see that in the right eye with clinically looked like a stage 2 to 3, and did not have a membrane, just kind of supported very nicely on the OCTA, and you can see that the deep capillary plexus is the one that's primarily borne the brunt, but there's no membrane, so you just observe this eye. The left eye, again, you do not need the OCTA to diagnose, but it's something that you can use to monitor and follow, and you can see that in the outer retina slab, which is avascular, you can see that very well-formed complex, and you can also see its imprint down in the choriocapillaris slab, which is shown by that red arrow, and which pretty much tells you what's going on. So that SHREM is also showing flow, even in the cross-sectional scan, so you know what this is. This is a stage 5, and this is PFT, and you treat accordingly. A case 2, which is going to be the last case, is again just to highlight one of the other causes of when you might see a gray structure / membrane in the macula, was of an elderly female. She presented with sudden vision, sudden onset metamorphopsia and decreased vision of 5-day duration, has 6/18 parts vision, has a dull, which, well, it doesn't look as gray there as it does in my photo, but yeah, was a little bit gray, had that. So she had like she had that PED, she had subretinal fluid, she had that irregularity of the RPE, and all of that going on. All of us know what it is, was treated with anti-VEGF, was diagnosed as wet. Sorry. Diagnosed as a case of left eye wet AMD with active CNVM, counseled about intravitreal anti-VEGF injections, went on to receive them, got the first one. You can see that the shape of the PED has changed considerably. It's become taller. There's maybe a prechoroidal cleft as well. The subretinal fluid is persisting. Received second dose of ranibizumab and complained of a drop in reading vision post that. So she got that. This is as gray a membrane as you might be able to see in the fovea. And if you go remember the checklist that we went through, RP alterations, RP tear, RP loss will also give you that appearance. And you can see that she unfortunately went on to develop a RPE rip, and it's actually folded. You can see that black autofluorescent area, and that's the comparative OCT. So the OCT, the autofluorescence, and the fundus appearance, which is gray, black, and that rip, kind of tells you, that is also something which will appear as gray, in the macula. We're not going to get into what causes RP rips and that, because that's not the cause for this. Just wanted to show that in this case, not only the primary pathology, but also a complication that happened subsequently, both tended to have a gray-looking appearance, and one needs to be aware that just everything that looks fairly similar might be the same disease, but entails different kind of prognosis for the patient. Thank you.
Thank you, Dr. Mohit, for a very nice talk. And I think, as he highlighted, OCT has definitely helped us a lot, because the moment we see these very subtle lesions also, if we do the OCT, it gives us the right answers. But I would suggest that when you are beginning, it is very important to still clinically evaluate the patient. Don't miss the opportunity of seeing the patient with the 90D or a plus 78D, and along with it, an indirect complete ophthalmoscopic examination in the periphery. Just because you see something on the macula and you want to get an OCT done quickly, you will miss a lot of things. Sometimes you will have edema in the center, and the pathology may actually be in the periphery. There may be leaking polyps, or there may be a leaking telangiectatic vessel in the periphery which is causing this. So don't jump to conclusions. You see a macular pathology, finish your examination, clinical examination, before you push the patient out for an OCT examination.
Another cause which I think can cause a grayish appearance can be heredomacular degenerations, which are very subtle. Patient's vision is poor, we are not able to explain. If you look very carefully, you find that there's an altered appearance, very little.
Yes, ma'am.
So that can be one cause for grayish appearance.
Absolutely.
And yeah, sometimes CSVR can also present like a
Yes.
grayish dot ablation.
So if you see all these subtle things and then you see the periphery also, you will realize that the grayish membrane is HMD and you have peripheral lesions as well. And then you can add on that, you can ask for an autofluorescence along with the OCT. So the patient comes back with the complete investigation package. Otherwise, you do the OCT, now you don't know what to do with it because it is not fitting into the clinical picture. So examine the patient completely, then you plan your investigations.
Excellent.
Thank you.
Presentation. You want to add something? Yeah. So I think is Dr. Muralidhar around? Yeah, sir. Please come. I'm sorry, we missed you. And of course, this grayish thing can always be compared with the fellow eye. That's again a very good thing. Right? If you have any doubt, look at the fellow eye. If refractive error is same, they should look same.
Good afternoon to everyone, and thank you, panelists, for this opportunity. I was actually given a curious topic of yellow spots and spots around the macula. Now that's a heterogeneous group, which actually we have a huge things. My life became easier when the first speaker talked about dot hemorrhages. The second speaker made it even better for me. So I could actually filter myself to white dots, which is more non-infectious than infections. So these are multiple whitish yellow inflammatory lesions which are located sometimes in the outer retina, in the retinal pigment epithelium, in the choroid. And in this heterogeneous group, I thought we'll handle only these non-infectious, which includes the placoid epitheliopathy. Bird shots, I just made it only for the academics, but we don't see bird shots in India. Mutes, then the multifocal choroiditis with panuveitis, then punctate renal chororetinopathy, serpiginous and azure. I just wanted to mention that the dots can also be seen in the periphery, like the Dallin fuchs in these either sympathetic ophthalmia or even in sarcoids over a time. So the differential diagnosis, actually, if we look at sarcoidosis, histoplasmosis, pneumocystitis, choroidopathies, Behçet's, toxoplasmosis, sympathetic ophthalmia. Intraocular lymphomas is one of the main things that we look at right now, and we also have the DUSN. So what is important in this is to differentiate between the dots and the spots. And based on that, we can actually classify whether it is large or small. And the large ones normally are the placoids and the serpiginous and the bird shots, and the small are usually the mutes, punctate inner choroidopathy, and the multifocal choroiditis with panuveitis. Now the distinctive and shared features that we have in these are majority are seen under the age of 50 years, except bird shots and serpiginous. Mostly seen in women, mutes, bird shots, and multifocal choroidopathies. Unilateral could be DUSN, or even mutes can present unilaterally. And most of the other ones are bilateral. I must also give a caution that although these are distinctive and shared features, they are not absolute. So you can have incidences even more than 50 years and even less than about 18, 20 years. So I think age would not be a real big criteria, and even gender sometimes might be misleading. The other distinguishing features are, despite the white dots remaining similar, most can be distinguished by the history, the lesion morphology and progression. Added to that are the ancillary tests or the fluorescein angio patterns and the OCT, along with the autofluorescence patterns, both in the blue peak and as well as the near infrared autofluorescence. And yes, where you have the facilities, visual fields, whether a full field or a multifocal ERG, would also help you to distinguish these. So individually, I would not like to spend much time because the placoid ones that I started, they do have a prodrome, although the reasons are unclear, and they are typically bilateral multiple plaque-like lesions at the RPE or the choroid. Usually they have an early block and a late stain on the fluorescein angio, but they usually fade away in 2 to 6 weeks in time. They rarely need treatment. Now, only if the prognosis is poor, which is associated either with a foveal involvement or an older age at presentation, unilateral disease, longer interval between first and second eye, recurrent diseases, and extensive multiple lesions, what we call as a relentless placoid retinopathy. These are cases which actually end up with a poor prognosis. Bird shots, actually, this entity is not common in India, and this is usually seen in the fourth decade in females, and this is mostly HLA-29 positivity, about 96%. But the HLA-29 positive does not show an incidence in the general population. The vice versa doesn't happen. I will not get into much of this detail because these are rarely seen, but most of these need immunomodulatory medications as a first line. Then we have the more common or multiple evanescent white dot syndromes, and these are usually affecting younger women, usually unilateral to begin with, and they could be bilateral. Unknown etiology. 1/3 have a preceding viral illness history and small degree of myopia. And on fields, you can get a temporal or a paracentral photomas. Ocular findings have very little inflammation. There could be small white lesions in the outer retina, and these could be ranging between 100 to 200 microns. And the macula appears very granular. I'm sure you can see the granular appearance on the right on the screen. And this is supposed to be pathognomonic of the mute findings. And they do have an enlargement of the blind spot. Now, OCT typically in dots and blots, if you look at it, dots are mostly in the middle retina and the spots are larger and at a deeper level. And it's actually very interesting that when you see these dots, the mutes on the retinal surface, we actually think as the outcome is better, so we think it as a common cold of the retina. So it just happens and it goes away. And this is exactly what you have. There is a disruption in the ellipsoid zone in the deeper retina, and it actually extends towards the outer nuclear layer. So fluorescein angiography, it actually shows punctate lesions and in a wreath-like configuration, and this wreath-like configuration is supposed to be pathognomonic for the mutes. I'll skip most of the other things in the interest in time. ICG also has a role in it, where many more hypox lesions are seen than what you see on the FA. And they are denser in the posterior pole and around the disc. And the clustering of these spots around the optic nerve is the reason for which you have the enlargement of the blind spot on the perimetry. Now, I think we'll skip this. And this is actually the visual field testing, where you look at the enlargement of the blind spots. And many of them are abnormal ECGs in the early phases, and they reduce in the dark adapted oscillatory potentials on the multifocals. So the multifocal ERG response is a measure of the photoreceptor and the bipolar layer, and the multifocal oscillatory potentials are the responses of the reflected inner retinal function. So, just giving you an example of how there has been a abnormality in the dark adaptation and the light things. You can see that there is subnormal wave patterns. treatment usually is very good. You don't need much of it, and they could get back normal vision. Serpiginous is more the larger ones, and I think this is also bilateral, but maybe asymmetric. The recurrences are very common in this lesion, and typically you find them as a grayish-white lesion with serpiginous or geographic-like extensions in the posterior fundus, mostly near the peripapillary area, but they can be seen anywhere. Active lesions are actually at the edge of the atrophic scars, and CNV may occur in these cases, and the treatment responses could be poor. Fluorescein angiography, if you look at it in an early phase, you can see the hyperfluorescence at the margin of the lesions, and on late phases, you can actually see them leaking. Multifocal choroiditis and panuveitis are syndromes simulating the POHS, the chronic idiopathic inflammations, and they represent a spectrum involving a punctate inner choroidopathy and a diffuse subretinal fibrosis. Please tell me when I'm overshooting.
Yeah, I think.
Up. So, do you want me to stop it here? Because most of the lesions.
You can conclude.
You want me to wind up? Okay. I wanted to only highlight the punctate inner choroidopathy, which is an inflammatory disorder, and this is bilateral. There are punctate choroidal lesions in the posterior pole area. The follow-ups, you can only realize this thing when you have a good serial follow-up. And once you document these cases, then you can actually find that 17 to 40% of the cases actually develop CNVs over time. This was one of my patients who actually was followed up for almost about 5 years, and we could actually see the CNV getting on at the end of it. Then you have the multifocal choroiditis with panuveitis, and this is very salient. The PIC and the MCPs have very interesting differentiations, and I think you can just go through this. I'll just leave this in the interest of time. I'll just take you through the last slide, that even though they are white dots, it does matter to distinguish them one from the other, to at least feel what spectrum of disease they are, because some get better with no treatment, some with steroids, and some with immunosuppression, and some with a combination of all this. With this, I would like to thank you, and thank you, sir.
Thank you, Dr. Muralidhar, with a very nice overview of white dot syndromes. And I think these are one of the most exciting retinal findings, which can end up anywhere from an innocuous MUDES or AMPP, or maybe some of them might end up becoming like developing into a full-blown VKH. So, but starting points are just white dots. And what I can see, some of the audience are like fellows and people who want to take up this medical retina. I would suggest 3 things to them. One is have your own collection of these photographs, classical OCT findings of different diseases saved with you. And whenever you see a complex case, try to match the findings to findings. Second is have a serial photograph and keep them in on one slide and see what happens to them over a period of time. And third, try to look into the number of layers involved, whether it was isolated retinal involvement or outer retinal layer or inner retinal layer, or whether choroid is also involved. I think the dreaded disease which we can miss sometimes is viral retinitis and foveal threatening serpiginous choroiditis. Those are 2 situations I can think of where if we not make a diagnosis correctly and confuse them with white dot, the consequences can be dangerous. Maybe Dr. Manav can add.
I think autofluorescence can be an important investigation modality in this type of cases that can give some added information.
Can I make a small comment? Yeah, I was just coming to that. Yeah. I purposely did not involve autofluorescence much in this because I was actually not knowing what was the audience. But in the interest of the audience, I can actually suggest I use normally 2 wavelengths in the autofluorescence regularly. One is the blue peak autofluorescence, which is more for your the lipofuscin material. But interestingly, if you use the near infrared autofluorescence, you have the melanin component, which actually shows you the abnormalities. So sometimes you might not pick up on the blue peak, and you end up looking at it on the thing, which can subtly tell you that, okay, there is some kind of a melanin metabolism abnormality which is actually showing up. The only drawback in this case is if you have an ellipsoid disruption bang under the fovea, then it's very difficult to pick it up even on the autofluorescence. Sometimes it gets drowned within that. That's what I all wanted to say. Thank you.
There could be other causes which can be hereditary dominant drusen.
I didn't.
And even Alport syndrome can have, lenticonus is classical,
Yes.
but very often fundus white spots can be there.
Right.
Alport syndrome.
That's true.
Yeah, but it's a difficult topic to cover, all the white dots. So we can spend the years talking about the white dots. Maybe we can go to the next talk now. I'll invite Dr. Veer. He will talk to us on shiny reflex on the macula. He's a vitreoretinal surgeon. He's an SN Luminous and now operating and working in Sohan Singh Eye Hospital, Amritsar. Still may not get the answers.
Yeah, the weekend sometimes it comes very classical, especially there is some component of dyschedema.
Thanks for the introduction, ma'am. A very good afternoon to the panel, the fellow speakers, and the audience. So mine is going to be a very opposite talk. It's going to be a very basic talk, which is going to basically act like a guide to the general ophthalmologist as to what to do when they see a shiny reflex in the macula. So there can be many causes for a shiny reflex, but we are going to focus on something like what this is. So that's an epiretinal membrane. So basically, what is an epiretinal membrane? It's a fibrocellular proliferation at the retinal surface. It causes distortion of the macula on contraction. There are many causes, but the most common one is an idiopathic with a 7 to 12% prevalence. There can be other causes can be iatrogenic, which is a cataract vitrectomy surgery or even a laser cryo, retinal vascular diseases, uveitis, retinal tears, associated with VMT, pathological myopia, trauma, tumors, ARMD, and even retinal dystrophies. The basic pathology is it consists of two layers. The light pink layer is the outer non-cellular layer, which sits on the ileum and is composed of non-cellular extracellular matrix proteins. The inner cellular layer sits on the ECM, and it mainly comprises of three types of epiretinal cells, which is comes from the retina, retinal glial cells, vitreous hyocytes, and the RP cells. These cells further transdifferentiate into myofibroblasts and cause ERM contractions. Pathogenesis, there are basically three theories. One is the classical theory, which says there's ileum defects and the retinal glial cells migrate to form these ERMs. The second one is the most accepted theory, which is an anomalous PVD theory. Residual hyocytes in the cortical vitreous remnants form the ileum after going metaplasia. And the third theory is just to explain the presence of RP cells in the ERM, which says that there's transdifferentiation and migration of RP cells through the retina and the ileum defects to form the ERM. Clinical features can be anything from a routine examination. Patient can be asymptomatic. It can be picked up on a routine examination. They can be reduced vision, metamorphopsia, or loss of central vision and scotomas, like seen in these pictures. Diagnosis is basically a combination of a clinical examination and one examination, which is the OCT, investigation, which is the OCT. On examination, you can see a shiny reflex, shiny membrane on the macula, absence of foveal reflex, a PVD can be present, retinal folds, ileum folds can be seen, and retinal vessel tortuosity or straightening can be seen. OCT is a gold standard investigation, and it shows the ERM as it is. The further that can show various different features, which I'll come to later. Grading of ERM is important because we need to grade them to see, to basically understand when we need to touch them. So it can be a clinical grading or an OCT grading. Clinical grading is basically a grade 0, which is a cellophane maculopathy. It's an early membrane, transparent membrane. There's no distortion of the retina. Grade 1 is a crinkled cellophane maculopathy. It's an intermediate stage translucent ERM on contraction. It causes disruption of the inner retinal layers. And grade 2, there's a premacular fibrosis. The ERM becomes thick, opaque, and causes full thickness retinal distortion. And the last picture, you can see a pseudo-hole formation. In OCT grading, this is what we follow, and this is more important. Stage 1 is foveal pit is present and there's a well-defined retinal layers. Stage 2 is foveal pit is absent and well-defined retinal layers are there. And stage 3 and 4 are ones which are important because this is when we need to operate these patients. The foveal pit is absent. There is present of something called an IFIL, or a continuous ectopic inner foveal layer. This is a hyperdense layer in the foveal region. Foveal pit is absent in the stage 4 and there is an IFIL, and retinal layers are also disrupted. Investigations, OCT is the single most useful test to diagnose an idiopathic ERM. Honestly, there is no other investigation that is required to plan management of these ERMs. Role of angiography is only to see a secondary cause. Retinal vascular diseases can be there, and underlying vasculitis can be there, vascular tumors can be there, and also to see the reduction or disappearance of foveolovascular zone in order to prognosticate the case. Other investigations such as multifocal, multicolor imaging, autofluorescence, microperimetry, and MFERG are mainly used for research and prognostication purposes. Management is basically observation and watchful waiting till the time the patient is asymptomatic. Vitropharmacolysis with ocriplasmin has been tried, but it takes care of the VMT, not the ERM itself. So definitive treatment is the surgical removal, and the MIVS era, our threshold is reducing when it comes to grading. And the important part is when we need to operate these patients. We need to operate these patients when they are clinically symptomatic. It starts affecting their daily activity. And also an OCT correlation is important. Like I said, grade 3 and 4 are the ones. Features here would be an opaque ERM or maybe a loss of foveal contour. Ellipsoid zone disruption is a very important sign, increased foveal thickness, etc. Timing is also important because longer the duration of visual symptoms and OCT signs, the poorer the visual recovery. Surgery is, the aim is to remove the ERM and release the retinal traction. Epiretinal membrane peeling can be done. I prefer to do a double peel, which is ERM plus ILM, because it reduces the risk of recurrence. A phaco-vitrectomy is preferred if the patient has cataract as well, because it saves the patient a surgery. Visual improvement occurs up to almost 3 years. So counseling is important. These are some of the cases that have been operated. The first one is a thin ERM in a silicone oil filled eye. The second and the third are VMT-related epiretinal membranes. And these last two images are diabetic-related ERMs. So take-home message would be the simplest test to pick an ERM is look for an absence of foveal reflex along with a shiny macular membrane. OCT, if available, is the gold standard for picking up these ERMs. If ERM is diagnosed before taking up the patient for a cataract surgery, a VR opinion is must before and even after cataract surgery. Counsel the patients accordingly, as the patient might start appreciating macular symptoms like metamorphopsia and scotomas even more after cataract surgery. Prefer to do a phaco-vitrectomy along with a VR surgeon, saves the patient a second surgery. So last but not least, this is just a 1-minute video showing a couple of cases in which different approaches have been applied to take care of an epiretinal membrane. In the first case, I take out the ERM and then I realize there's a very unhealthy and a folded ILM underneath, so I go for the ILM after that. And in the second case, there's a thick pucker, so I go straight for the ILM, away from the pucker, and start peeling the ILM. And slowly this epiretinal membrane, the pucker, comes off along with the ILM peeling. Here, I restain just one more time to see where the ILM edge is. And then you see that the ILM edge is there. And slowly and steadily, going around the macula circumferentially, the epiretinal membrane slowly comes off. Basically, pinching again and again and pulling a little bit loosens the membrane, and you should be very patient doing this. With that, thank you.
Okay, very nice presentation, Dr. Veer. So only thing that most important is to understand when to go in for a surgical intervention. So once you see the grayish membrane, you diagnose it that it's an epiretinal membrane, not only because of the fundus examination, patient symptoms. Another thing which is becoming very common is that OCT is done as a routine for a lot of patients before cataract. And once you do that, you see a thick membrane or a little taut membrane on the macula, and you decide there is ERM, so it needs surgery. So it is not like that. So until unless the patient is really symptomatic, having complaints of metamorphopsia, you see the visual acuity, then you take a call whether really the membrane needs to be removed or not. Sometimes a shiny reflex on the macula can stay for years together and patient may not need membrane removal at all.
The other causes for shiny reflex again is heredomacular degeneration can be there, or even perifoveal telangiectasia can have a shiny appearance at the perifoveal area.
It was actually very difficult to actually cover everything, so I mentioned the causes and then I focused on epiretinal membrane.
And even ischemia also, like sometimes macular, you rightly said that go for an angiography if you are suspecting a secondary ERM. So especially your vision loss and structure on OCT should commensurate.
Yeah.
If it is not, then you should better investigate more.
Yes.
Also, sometimes you do an angiography and you see leakage and you start thinking whether it's an ERM or it's a choroidal neovascular membrane. Sometimes because of the distortion, you will have leakage in ERM also. So that let that not confuse you.
So I think next we'll have Dr. Avnish Upadhyay, who will be speaking on disc edema. Again, a very common finding in our practice. We do fundus evaluation and find a patient with disc edema, unilateral or bilateral. Dr. Avnish is a senior consultant with the IQ Subspeciality Eye Hospitals. Over to you, Dr. Avnish.
Thank you, sir. इसमें नहीं है पीछे हॉल है इसके नीचे Good afternoon, everyone. So my topic is about disc edema. So a couple of things before we actually chip in. Basically, there is whether actually we have a disc edema or not, that is one thing. And normally a disc edema can be unilateral or bilateral. So this is how we are going to proceed with the discussion. So basically, before going into a true disc edema, we are going to talk about pseudo disc edema first. Basically, there is an elevation of the optic nerve head or peripapillary tissues without any exoplasmic stasis. The possible causes could be optic disc drusen, anomalous vessels, vitropapillary traction, morning glory syndrome, Buckminster's papillary, medullated nerve fibers. The features here we need to look into is how the disc is. It is usually yellowish. The vessels are more abnormal. There could be bifurcations or trifurcations. There is no associated hemorrhages or exudates or cotton wool spots. And if you do an FA, there won't be any leaks. Just more of a discussion on optic disc drusen that is commonly seen. So it is basically a proteinaceous material within the retinal ganglion cells. Most commonly, if you need to diagnose this, these patients do not have vision drop or they don't have an RAPD. If you are confused whether the patient has an optic disc drusen, kindly do an autofluorescence and you could actually see a hyperfluorescent bodies could be picked up. OCTs are a newer way in where you can actually see these low dark signals followed by along with hyperreflective bands above the lamina crepullosa, and still not possible. So you can do a B scan, you can actually pick up these highly echogenic with postacoustic shadowing. So coming to true optic disc edema, there is swelling of the retinal ganglion cells with exoplasmic stasis. And you actually need to see with your binocularly there is an elevation of the disc on indirect or slit lamp. There is associated edema of peripapillary nerve fibers, peripapillary hemorrhages are there, congestion and hyperemia of the disc, along with peripapillary folds or subretinal fluid, unlike what we saw in pseudo disc edema. So if a disc edema can be unilateral or bilateral, just a discussion on unilateral. So if you have identified it's a true disc edema, you have to take a thorough history of the patient, in which it includes visual symptoms, whether the patient has blurring of vision, whether the scotomas are there, if it is associated with pains. You have to see for symptoms of raised intracranial pressure, where you have to ask for presence of any headaches, tinnitus, or transient vision obscurations, associated lateral nerve palsy if there is. Check for signs of meningitis, that is either there is associated fever, neck stiffness, or focal neurological signs. After the history, you need to assess the visual functions, how the vision is. You have to do a color vision just to see if it is changed or dropped. Check for an RAPD, and followed by if you can do a visual field testing in the OPD itself. Followed by good ocular examination. Ocular examination should be anterior in the FUNDUS examination. In the posterior segment, do look for signs of vitritis or retinochoroiditis if there is, and associated vascular changes if there is, where there is vessel attenuation, sheathing of vessels, or presence of any optociliary shunts. And then you can go for the formal visual field testing, look for OCT findings, fundus photos, and autofluorescence for your confirming the diagnosis. So most commonly, we have this true disc edema, which is there. It can be unilateral or symmetric. And that is the most commonly it is secondary to raised intracranial pressure. And when you see these sort of patients, there is an asymmetry in the disc edema, and there is no presence of an RAPD, unlike what we see in optic neuropathy. So one of the true signs which you can look in, if there is a disc edema, look in for the vision, look in for an RAPD. If the RAPD is not there, usually you don't tend to have, the diagnosis goes more towards going into papillary edema rather than going into a neuropathy. So coming more into about benign intracranial hypertension, where we have diagnosed that the patient is possibly having a BIH. So it is usually seen in females of childbearing age with an elevated BMI. They may have the symptoms which we mentioned before. We need to ask about their medication history of tetracyclines, vitamin A derivatives. You do an field effects are normally not there. And in these sort of patients, we need to actually confirm our diagnosis doing an MRI with contrast with MR venography. So these are some telltale signs where we can actually pick up there is a raised intracranial pressure, in which we can actually see a flattening of the posterior sclera, distension of the optic nerve sheaths we can see here, and partial or empty cella, and we can actually have stenosis of the sigmoid or the transverse sinus. So these are some signs which can pick up. When the patient has an edema and you do an MRI, and these are the signs which can actually confirm our diagnosis. So if it's a BIH, the treatment is weight loss. The patient is asked to reduce weight. We give acetazolamides, and in refractory cases, venous sinus stenting could be done.
Skip the treatment part, and I think we'll have to.
Coming to optic neuritis, as we mentioned before, these patients can have, you look for an RAPD and ask for associated pain on ocular movements. If that is there, the treatment, the diagnosis is more towards optic neuritis. And it could be idiopathic, or it could have some sort of associated infections or inflammatory problems. So the MRI with contrast could pick up optic nerve sheath enhancements. And these are some of this investigation one should do. So this is one flow chart where you can see if it's a optic disc edema. We need to rule out if it's a pseudo disc edema or not through our scans. And then once that's done, we can have abnormal neuroimaging if it is present. The possible causes could be papilledema or an optic neuritis or a meningioma. And if you have a normal neuroimaging, the possible causes would be an NAION or ocular inflammation, vein occlusions, diabetic papillitis, neuroretinitis. So NAION could be seen with an acute loss of vision with optic nerve swelling. It could have a diffuse or a segmental disc edema, which can be picked up on a HFA. And the treatment is not there. And the risk factors could be, we need to treat the risk factors, that is sleep apnea, hypertension, diabetes, smoking, stopping smoking, and hypercoagulable states. Other things which we actually need to look into disc edema.
I think this bit has been covered already.
Fine,
so because of paucity of time, unfortunately, we can't have too much of discussion on this also. Maybe one comment from you, and maybe Dr. Malika can add the concluding remark.
one, ma'am, I just wanted to emphasize about bilateral disc edemas, which we commonly
Yeah,
tend to
sure,
see in
you
our,
can just
this
finish.
is hypertensive retinopathies. So if you have a younger patient who comes with bilateral disc edema, instead of doing an MRI, check for the blood pressure. And then after that, you can, if the blood pressure is normal, then you can actually go back doing the MRI and going into the treatment part. That's it. Thank you.
I think excellent presentation, and because we have paucity of time, we can't have discussion now. But I think you rightly said, look into retina also. Don't ignore retina once you see disc edema. Many times cause is lying in retina or choroid. So I think it was a nice session. Thank you all for your attentive listening. And shall we?
Yeah, we'll conclude
We'll
now.
be concluding and hand over the hall to the next sessions panelist. Dr. Ajay is already ready.
Thank you so much.
Thank you.